the disturbing.
Okay, so important is because now we are getting the patients of our own, and they're approaching pain physicians directly. So whenever the patient comes to us, now we are the one who are going to diagnose the patient, right? If you have to do some intervention, if you have to manage the patient, maybe conservative also, whatever it may be, and especially when we talk about the interventions, that time it is the responsibility of the pain physicians to exactly come to the diagnosis first, and then we can decide our intervention. So for that, it is important, if you've seen all the reports, wherever you get the reports, it is always mentioned in that please correlate clinically, right? Because why they mention this is because whatever they are reporting on the basis of the whatever is visible to them. But as a physician, it is important for us to identify exactly what is the source. There may be multiple pathologies, but since we have examined the patient, we know the clinical history of the patient, so we have to correlate clinically and with the MRI radiological findings what is matching with the patient's symptoms or the history. And accordingly, we have to select the intervention. So for that, it is better to use the films, start reading the films. So whenever you have a patient who comes to you with even if the patient doesn't have MRI, what MRI to order, that is also your responsibility. Okay. Once the patient comes to you with the MRI, how to read that, how to identify the pathological areas, that is your responsibility. Even if the patient is already having some MRIs with them, don't just look at the MRI reports. If you see the MRI reports, there will be multiple things which are mentioned in the MRI reports. You will get confused. So better to examine patient clinically, interview patient properly, see the MRI films, make a clinical diagnosis, provisional diagnosis, and then maybe you can look for the MRI reports. Okay. So for that, you must know how to read the MRI. Okay. Uh, I'll cover a little bit of the X-ray and the CT scan of the spine also. So X-ray is basically the basic investigation we all know. It's mainly done for the spondylitis, spondylolysis, listhesis, and the fractures. So what is spondylitis? Spondylitis is not an inflammatory condition, but it's a degenerative condition of the spine. So when we see on the X-ray some facet arthropathy, osteophyte formation, or some sclerosis of the end plates, then we call it a spondylitis. Because inflammatory condition we cannot see on the X-rays. Let's be very clear on this. So spondylitis is a degenerative condition of the spine. Like in osteoarthritis, it's a degenerative condition of the joints. Similarly, spondylitis is the degenerative condition of the spine. Spondylolysis means whenever there's a break or fracture in the pars interarticularis, then we call it spondylolysis. Whenever we have this break or the fractures on both the sides, pars interarticularis, then there's a break in the from the posterior and the anterior segment. They are separate, and that will lead to the spondylolisthesis. That means slippage of the vertebral body. And obviously, the fractures are the one which we can see on the X-rays. Especially your osteoporotic. For what is important for us is the osteoporotic compression fracture or the metastatic or the traumatic compression fractures. So these are significant for us. Yes, anyone? You can stop me anytime. You can ask me anytime in between. Okay. So this is a typical X-ray of the LS spine, where we know all the structures. What are structures are there? Spinal process. Are there. If you don't have any question, you can mute yourself.
I have muted all. You just unmute yourself and please continue.
I'm muted.
Somebody's voice was there. So
Can you hear me now, Kashina?
yes, sir. Yes, sir. We can hear you very much.
Okay, all right. So we know that this is a vertebral body over here. There's a pedicle over here. There's a transfer process. We have this lamina over here, the inferior lamina, the superior lamina over here. That's the interlaminar window. This is the interlaminar window over here. This is the lamina, the inferior lamina, the superior lamina over here. And that's a vertebral body. And this is the intervertebral disc. Superior articular process, inferior articular process behind this, and that forms the facet joint. So that is already been covered in the fluoroscopic anatomy. In the lateral view of the X-ray, we see the vertebral bodies, intervertebral disc space. We see the pedicle. Now we cannot see the transfer process. What we see is the shadow of the transfer process. And if you follow this pedicle over here, we see the inferior articular process. And if you follow this pedicle over here, we see the superior articular process. And again, we have a transfer process over here. And these are the spinous process which are behind in the posterior part. And these are the foramen. Foramen, as we know, that it is two parts, upper part and the lower part. The upper part belongs to this vertebral body, and the lower part of this foramen belongs to the both the vertebral bodies. So this is the intervertebral foramen, and this is the suprapedicular notch. This is the infrapedicular notch, and this is a facet joint over here. This forms the facet joint, inferior articular process, superior articular process, and this is the lumbar canal over here, which continues with the sacral canal over here. And this is a sacral border which is fused. Now there is a fusion over here, and you can see the shortage of the spinous process over here. So on X-rays, we can identify the disc degeneration. How we identify them? There's a disc space narrowing will be there. At times, we may see some gas inside the between the inside the disc, which is a sign of the degeneration. So this gas is basically nothing much but it's a nitrogen gas which gets accumulated because of the degenerative process. Now, since there is a lot of sclerosis over here, there is no escape route for the metabolic end products, and that's why it gets accumulated inside the disc, and it forms a white line over here. So on X-ray, it will look dark, but when we see them on the fluoroscope, it will look white shadows over here. Okay. What is important for us is to see this. Now look at this. These are called small nodes. All these small nodes or the end plate changes, they are not painful. How we make out that whether it is painful or not? If you look at this and these end plates, they have a smooth margins. There is no irregularity in the margin. Okay, there is no irregularity in the margins. They are smooth margins. They are just like a depression into the end plates. So these kind of end plate changes, they are not painful. Whereas if you look at the X-ray over here, if you see some erosions over the end plate, and if you only have the X-ray with us, in that case we must suspect some pathological things going on inside the body. Now this could be because of some infection also. This could be because of the severe degeneration, or maybe because of metastasis also. So these are the conditions which we should suspect where we see end plate erosions. Smooth end plates, we should not bother about them, but erosions are there, then we should suspect some clinical pathologies. Oblique X-rays, as we know that for the facet arthropathy and the pars interarticularis, we had to go for the oblique X-ray. So when you are suspecting facet arthropathy or the spondylolysis, don't just order X-ray LS spine AP lateral. You have to order X-ray oblique, right or left, whatever side it is. Then only we'll be able to make out the facet arthropathy or the pars interarticularis defects. Look at his there. You can see here, this is the pars interarticularis over here. Pars interarticularis, which is again in the layman term we can call it as the neck of the Scotty dog. You can see there's a breach in the pars interarticularis. Okay. Both the conditions, whether it is spondylolysis and a facet arthropathy, they almost present in a similar fashion. Clinically, they present in a similar fashion. The patient will have pain on the twisting movements. The only difference which we get in the pars interarticular defect is at times the patient will also tell you, when I move or when I turn, I get a cracking sound inside. If we are getting a cracking sound, you must suspect some pars interarticularis defects. Spondylolisthesis, So whenever we are suspecting spondylolisthesis, so what are the conditions, clinical conditions where we suspect spondylolisthesis? So these are the patient who will present to you with the less of the back pain. They will have some back pain, but their main complaints would be that they will feel that they are getting some neurogenic claudications. So when they start moving, when they start walking after a certain distance, they will say that my both the limbs start getting numb or heavy. So that is the time when we suspect some lumbar canal stenosis, and this stenosis could be because of the spondylolisthesis. So when we are suspecting spondylolisthesis, again it is important for us to understand that we must order X-ray, standing X-ray. Okay, it should not be in the spine position. It should be standing X-ray. Along with that, we should have AP lateral. Along with that, we should have fraction extension, because fraction extension will tell you whether it is a stable listhesis or it's an unstable listhesis. If it is stable listhesis, patient is having stenotic symptoms. In that case, we can still go with the decompression, posterior decompression. But if it is an unstable listhesis, these are the patient who requires fixation, surgical fixation, or percutaneous fixation. So that is why it is important to establish whether it is stable listhesis or unstable listhesis. Also, we can see the SI joints on X-ray. This is one of the intersection of choice for the advanced spondyloarthropathies like ankylosing spondylitis. But we must remember, whenever you have a patient who comes with the sacroiliac joint pain, remember in the sacroiliitis, all these features, that means fusion of the SI joint or the sclerosis of the SI joint, these are very late features. Especially if the patient is a young patient in their 20s, if they come with the sacroiliitis, don't order X-ray of the spine or the SI joints. Because in the initial stages, initial phases of the spondyloarthropathies, it is an inflammatory kind of arthropathy. Okay? In that case, what will happen? X-ray will look normal. Even if you have a high suspicion of the ankylosing spondylitis, and if you don't see sclerosis or the fusion, you may say that this is normal. Patient may come with a normal report of the X-ray of the SI joints. Okay, but the patient may be having severe pain. So whenever you have a suspicion of the spondyloarthropathies, you must order MRI. Don't rely on the X-rays. All these features, fusion, erosions, these are very late features of the spondyloarthropathies. Also, there is some condition when we don't see any much deformities, but there are some variations which are there in the X-rays, like and lumbaration or the sacralization. That means either this is the lumbar vertebra, the S1 is not properly fused with the sacrum. In that case, they will start forming the pseudo joints. Now look at this. There is a pseudo joint over here. Okay, this is not completely fused, and it forms a pseudo joint over here. So at times, these kind of joints, they also may be the source of the pain. This is also called the Bartolini syndrome. Okay. Now look at this. Now suppose there's a lumbaration of S1 over here. But this is absolutely behaving like a lumbar vertebrae, not fused or not partially fused with any of the structure, bony structure over here, neither with the sacrum nor with the ilium. So it is behaving like an independent vertebral body. So all the movements which are happening, we have a proper disc over here. Okay, the joints, there's not forming a knee joint. So it is behaving like an independent vertebral body, and the movements are happening smooth. So these are kind of conditions, they will not cause any pain because of the lumbaration or the secretion of the vertebral bodies. But if you see here, there's a partial fusion which is happening with the ilium. So these kind of conditions may cause a arthritic kind of changes and may cause pain over there. Similarly, here you can see here, there's a long transfer process, big transfer process over here, and is trying to fuse with the sacrum, but it is not completely fused, so that it behaves like a joint. Now these joints are the pseudo joints. So when we say pseudo joints, means they do not have their capsule, They do not have any articular surface. They are just bone over the bone rubbing against each other. Okay. Now look at this condition where it is already fused. They are already fused. Okay. This is a lumbaration of the S1 vertebra, but this is completely fused over here. Or this may be sacration of the L5, which is again fused with the sacrum. So such conditions are usually are not painful because this is already fused. There is no joint over here. So these kind of condition may not cause any pain. But what happens whenever you have this kind of lumbaration or the sacration, especially the sacration of the L5, in that case, the motion segment, which should be from L1 to L5, now the motion segments have reduced. That is only between L4, L1 to L4. So what happens? All these joints they start getting excessive pressure on these joints. So these patients may present not because of this lumbaration or sacration of the L5, but because of this lumbaration, there is excessive pressure on the facet joint at the above level. So these patients may present with the facet arthropathy at L4, L5 level. Okay. CT scan is at times it is required whenever we are suspecting some bony stenosis, when we are suspecting some calcified ligaments, when we are suspecting some calcified disc over there. Especially in the chronic long-standing disc herniations, the fragment which comes out, it gets calcified. Especially it is important when we do spinal endoscopies. That time we have to rule out whether it is calcified or not. For that we have to go for the CT scan. CT scan is, as you know, that it is not good for the soft tissues, but it is good for the bony tissues. So if you have this arthritis changes or the facet arthropathies over there, then you may be able to visualize all the joint reduction, joint space, and the osteophyte formation over the facet joints, which is clearly visible on the CT scan as compared to the MRIs. Degenerative changes of spine, you can see all the degenerative changes over here. You can see this vacuum phenomena over here, all the sclerotic end plates over here, a lot of osteophytes over here, reduction in the joint space. So all are the features of the spondylitis. Spondylolysis, when you're suspecting past defect, again, CT scan is a better option, or the oblique X-rays. At times, they may be able to differentiate the facet arthropathy with the spondylolysis, that means past defects. Vertebral fracture, especially if you're planning for the vertebral augmentation procedure. In that case, if you are suspecting some posterior cortical breach, in those cases, you may go for the additional investigation, which is a CT scan, to rule out any bony fragment, which is going into the spinal canal. Especially, it is very important if it is post-traumatic fractures. Post-traumatic fractures, if you see some posterior cortical defects or destruction, in that case, it is better to go for the CT scan. Provocative discography, post-provocative discography. So once we do the discography, which is like putting a pressure inside a disc to generate a pain, that is called discography. And post-discography, we send this patient for the CT scan to identify the tears. Now you can see here, this is normal disc. So that's why the contrast is within the disc material, nucleus material. Annulus is intact. So that's why it is limited to the nucleus material. There's a breach in the annulus. So that's why the contrast has come out and is forming the high intensity zone, which is clearly visible on the MRIs. Okay. Here also you can see there's a big herniation, big tear. That's why the contrast is coming out over here and getting accumulated over here. Calcified ligaments, especially the posterior longitudinal ligaments, if they get calcified, they're difficult to visualize them on the MRIs, but we can see very clearly them on the CT scan. For spine, test of choice is definitely MRI of the spine. Okay. But before that, we must understand. Now look at this graph. This is very important study which was done at multi-center study. Percentage of the disc degeneration present in asymptomatic patients. That means these are the patients who never had any back pain. Okay, and look at this, the percentage of disc degeneration. At 20 years, 37% of the patient, they were having evidence of the disc degeneration on MRIs. 40 years, 68% of patients, they may not be having any pain. These are patients who are asymptomatic patients. So disc degeneration is not always painful. Okay, so that is why what is important is that we must correlate clinically with the patient symptoms. So this is the kind of MRI films what we get, right? We get multiple images, multiple films where we have sagittal sections, axial sections, coronal sections, T1 images, T2 images. All of them have a lot of significance. Everything we have to read. It's not only the central MRI which we see. At times you may have a big film over here, which is showing entire LS spine. Okay, this is the film. What you are seeing over here, at times you should never look at that. You should never look at that. Okay, understood? Because that is taken from the center. Okay, so don't look at that MRI. If you have that MRI films, don't see there and don't make any interference out of that. So you have to see all the sections, all the sequences. They have a lot of significance. We'll discuss that now. So why MRI is important? MRI is not only to make a diagnosis, but also to decide what type of intervention we want to do. What type of intervention is going to benefit the patient. So for that also, we must know what are the pathologies on MRI. So MRI will show the architecture of the disc, whether it is hydrated disc or desiccated disc. Okay, why it is important? Because if it is hydrated disc, contained disc, we may go for some interventional procedures which are very minimally invasive. If it is desiccated disc, usually these desiccated discs, which looks more horrible on MRI, but they are not painful. Okay, as compared to the hydrated disc with the small tears, dysfunctional end plates, annulus. Disc is hydrated, maintained heights, okay, but there's a small tear in the annulus. This may be painful. But desiccated disc, which is like a totally dark disc, totally desiccated, reduced reduction of the joint space, the intervertebral space, that may not be painful. But such a small annular tear, or the defect in the end plates, that may be very very painful for the patient. Secondary changes in the form of body changes that we'll discuss in detail. So secondary changes, body changes are basically the end plate changes, which happens because of the disc degeneration, which leads to the changes at the end plates. So there are different types of end plate changes, which we'll discuss because every type of end plate changes will have different modalities to treat. They will have different presentations. Okay, herniation. Obviously, we have to see what type of herniation it is, whether it is a contained herniation, extruded herniation, or the sequestrated herniation. If it is extruded, sequestrated, where it is migrated, whether it is upward migrated, downward migrated, that also we have to see. Because in those cases, our target is the fragment, which whatever has come out, that is our target. So that fragment, where it is lying, whether it is at the disc level or migrated upwards, downwards, that we have to see. So that accordingly we can target a fragment. Standing MRI for the listhesis, it is not always required because listhesis we can easily make out on the X-rays. But if you have this facility of standing MRIs in case of critical stenosis, where we want to see that whether we can, there are some patients who may come with the old age or maybe multiple morbidities which are not fit for the fixation surgeries. If the patient is not fit for fixation surgeries, in those cases we may go for the standing MRI to see what is the source of the compression. At times, because of the listhesis, there's a ligamentum folding or maybe pseudo herniation of the disc that is compressing the nerve roots. In that case, we can do the decompression from the posterior or from the anterior, the disc decompression, and without fixing the spine. Canal stenosis, again, we have to see on MRI what exactly is causing the stenosis. It is not always the disc which causes stenosis. Remember this. Many times we don't even touch the disc. When we do decompression, endoscopic decompression, we don't even touch the disc. Because disc leading to stenosis, critical stenosis, is actually not that common as compared to the flavum and the osteophytes or the facet-arthropathies or the listhesis. So all these are the conditions which may cause canal stenosis. So don't just look at the disc. Okay, malignancies may be primary malignancies or the most common is the secondary malignancies. What is the significance for us? We want to see what type of malignancy it is, whether it is a osteolytic lesion, osteoblastic lesion, or it's a mixed kind of lesion. Because we know that osteolytic mixed kind of lesions may be painful, but osteoblastic lesions are always not painful. Even if it is painful, what we can do is we go usually for the vertebroplasties or the cementoplasties, right? Osteoblastic lesion, if it is there, then obviously we cannot do cementoplasty in those cases. So we have to see what type of malignancy it is, what type of metastasis it is. Now, cysts also, we have different types of cysts, where whether it is a facetal cyst coming from the facet joints, or it is coming from the arachnoid, that means the covering of the nerve roots, that is causing the cyst, or it may come from the disc itself. When the disc starts accumulating the some exudate over there, it may take a shape of the cyst, and that starts compressing the nerve roots. So modality of the treatment is totally different depending on the type of the cyst. Even if you do not have any suspicion of anything, or some at times we have to rule out the infection. Before doing any intervention, we have to rule out the infection. Especially it is commonly what we see is that patient comes with sacroiliitis, clinical diagnosis, absolutely yes, clinically patient is having sacroiliitis, but still before intervention, we must take an MRI to rule out infective cause. Because as we know, tubercular sacroiliitis is not uncommon in India. So we must do an MRI before doing any interventions. Okay. In, at here in IPC, we always do MRI. Without MRI, we don't do anything. We don't touch the patient. Okay, now we'll try to understand what are the sequences of MRI. Okay, guys, clear so far? Any doubt? Anything you want to ask?
Yes, sir. Clear. Any doubts?
Okay,
Okay,
talking
go ahead.
about the sequences of the MRI. So normally we look for the T1 and T2. Okay, so what is T1 and T2? What is the difference between T1 and T2? So when we see T1, let's divide this into three parts: water, fat content, and the soft tissues and the bones. Okay, so bones, ligaments, muscles, all they come into one category. Hmm? So when we see T1, water looks hypo. Hypo, let's for the to make you understand, hypo means it is dark. Hyper means white. So whenever white is there, I'll say it is white. Hyper is there, I'll say white. Hypo means dark, dark and white. Okay, for you to understand it clearly. So T1 and T2. On T1, water looks dark. On T2, it will look white. Okay, fat fat will be white on both T1 and T2. Bones, muscles, ligaments, they will be dark on T1 and dark on T2. So what is the difference? The difference is only with the water content. Wherever there is a hydration or the water content, there will be a difference in the sequences of T1. It will be dark on T1 and white on T2. Okay. Now look at these sequences over here. These are center sections. Now go from posterior. This is skin over here. Subcutaneous fat, this is T1, fat is white, T2, fat is white. Go anteriorly, interspinous ligaments, spinous process, interspinous ligament, spinous process, they are dark on both T1 and T2. It falls into this category. Fat will fall into this category, it will white on both, white on T1 and T2 both. We'll go more anterior, we'll see some darker structure over here on both. You can see a slightly more darker as compared to other ligaments. This is the ligamentum flavum. That's the ligamentum flavum. Okay, this is the ligamentum flavum. Now, if you go anterior to the ligamentum flavum, again we see a white structure over here, and we see a white structure over here on both T1 and T2, which is your epidural space. Now, why it is white over here on T1 and T2? Because epidural space, as we know, that it has a fat globules, fat content is there. So that's why it will look white on both T1 and T2. Okay. Now, as you go more anterior, now you can see some darker structure over here. And if you look closely over here, you can see some darker structure over here. So these are the nerve roots over here, bunch of the nerve roots which are hanging in the CSF. Now CSF is water, so it will look white on T2, it will look dark on T1. Go more anterior, we will see the vertebral bodies, they will look darker on both T1 and T2. Okay. Now look at this vertebral body over here. This is white. This is white over here. Okay. So white structure in the T1 and T2 both. This may be either fatty infiltration or this could be hemangioma also. So to rule out, what they will do is the radiologists, you don't have to order that. They will do it themselves. They will go for the stir images. That means they will suppress the fat. So wherever there's a fat, it will get suppressed, and the white, which looks white on both T1 and T2, it will start looking dark on T1 and T2 both. Okay. So when we suppress the fat, this is a star image. When we suppress the fat over here, now look at this fat, wherever the fat was there, subcutaneous fat, epidural fat, within the vertebral body, again we can see it has become dark. So that means this was not a hemangioma, this is a fatty infiltration. Okay, understood? Now this is the basis of reading MRI. So we must be very clear on this. Guys, whenever you have any question, don't write in the chat box because it's difficult to see that. You can simply unmute yourself, stop me and ask me there only. Okay. That will be more easy to understand everyone. Okay. Whatever you have doubt, you can always ask me. Okay. So we'll take this. Okay. Somebody is asking about a vacuum phenomena. What do you want to ask about a vacuum phenomena? Mahi?
I think he answered when you were showing.
Oh, acha, acha. Okay. Okay. All
Yeah,
right.
yeah, yeah.
Okay.
But there are two more questions, sir. Yeah,
Okay.
importance of
So what is
hemangiomas in spine and
uh,
what is treatment option for Modic type
okay.
3 changes?
Okay. So, okay. We'll come to that. Mahi will come to that. Treatment options for the moderate type 3. I'll come to that. When we discuss about the body changes, I'll come to that. What is the importance of hemangioma? I'll just take this now. Okay. Okay. Now look at this MRI. Okay. These are sagittal sections. So guys, you need to contribute here, huh? What section? What sequence is this?
T2.
T1.
Yes. So the first, uh, whenever you see this image, the first thing what you have to see is the CSF. Just look at the CSF. Looking at the CSF, you can make out that whether it is T1 or T2. Look at the CSF, it is dark here, this is white here. So obviously, this is your T1 and this is T2. Okay, clear? So first thing what we see is the CSF. Look at the CSF and see that it is T1 and T2. CSF is white here, CSF is dark here. Okay. Look at this here. It is white over here, it is white over here. Okay. This both are white. If it is
Fine.
CSF, if it is CSF, it should have been white, dark over here, right? On T1. But it is white on T1 and white on T2. To identify that, we can go for the suppression, fat suppression, and now we can see that this is not a CSF, but this is a fat. This is a epidural lipoma. Okay. Now, one thing which I wanted to show you here is that now can you see here disc? Can you make out some difference between this disc and this disc? Okay. You can see it is a diffuse dark structure over here on T1. Whereas on T2, it is dark outside in the periphery, and in the middle center, it is slightly whitish. So what is that? It's a because it's a nucleus pulposus,
Hydrated
nucleus
blood.
pulposus which is hydrated. That's why hydrated portion on T2 it will look white, whereas everything wherever the water is there, it will look dark on T1 images. Okay, so this is again a sign of the healthy disc. Okay, when we start losing the hydration, it will start becoming dark like this. Okay, now hemangioma. Hemangioma and fatty infiltration is suppose if you do not have a stir image. Not many times this happens that the patient goes to the MRI center, they have a fixed sequences, sections, they'll send you the MRI films, and these MRI films are uploaded to the radiologist who may be sitting 1,000 kilometers from there and is reporting based on the films provided to him. Okay, so in that case, now you have to identify whether it is a fatty or the hemangioma. Okay, now looking at this whiteness inside the vertebral body, if you look at this, you can see some black linings over here, right? Can you make out those linings inside?
Yes, sir.
So such kind of linings within the vertebral body and whiteness in the vertebral body, this is a sign of the hemangioma. Whereas if it is a fatty infiltration, it will be like a diffuse white without these linings inside. Okay, so this is again a method where we can identify whether it is a fatty infiltration or it's a hemangioma. Okay, now look at this. What is this? Whether it is hemangioma or fatty infiltration?
Hemangioma.
Yes, very good. Because we can see some linings over here, and this is a hemangioma over here. Okay. Now hemangioma, somebody was asking what is the importance of hemangioma? Hemangioma, they are not painful, they are benign structures, benign pathologies. Okay. So such kind of hemangiomas are incidental finding in most of the cases. We just send a patient for MRI for some other pathologies and we see them on the MRIs that there's some hemangioma inside the vertebral bodies. Now you have to decide whether this hemangioma is actually pathological or it's just a benign condition. How will you make out this? Suppose there is nothing, no other abnormalities, okay, and there's a big hemangioma over there, and the patient is complaining of pain in that area. Okay, so that means it's a painful hemangioma. Okay, most of the times, almost 80-90% cases, these are not painful. But if they cause pain, if they are the source of the pain, if you can correlate them clinically, that this is the site of the pain, and this is where we have actually exactly where we have a hemangioma, in those cases, we can decide to go for the vertebral augmentation or the vertebroplasty. In fact, vertebroplasty, this is the first indication of the vertebroplasty. Hemangioma is the first indication. When it was introduced mainly for the hemangiomas. Okay, so if it is painful hemangioma, it's a very good condition for it's a very good indication for the vertebroplasty. Now, if I say that this hemangioma is a contraindication for vertebroplasty, look at this. This is again hemangioma. This is also hemangioma. But I'm saying this is a perfect example of the indication for the vertebroplasty. This is an absolute contradiction for the vertebroplasty. Okay. Now what happens? A patient comes to you with this MRI. MRI says hemangioma. Okay. It's painful. Now you have identified that it's painful for the patient, but you have to decide the intervention. Now, if you look at this posterior cortical wall, look at this posterior cortical wall. Can you see this concavity over here? Guys, can you make out?
Yes, sir.
You need to respond. Somebody need to respond so that I know that you are listening.
Yes,
You
sir.
can see this vertebral body is concave. This is maintaining concavity over here.
Yes.
Both are maintaining concavity, whereas this is
Convex.
yes, perfect. So that means it's a bulging hemangioma. Okay, which is a malignant hemangioma, which means there is a feeder artery over there which is supplying this hemangioma. Okay, and this hemangioma is so malignant that it is basically eroding the cortical walls, which are quite thick, but it is eroding the cortical walls. And since there is a blood supply to this, this becomes a contradiction because if you go inside this, if you try to do the vertebroplasty in those patients, these patients may start bleeding and you cannot even control that bleeding.
Sir, in this type of hemangioma, should you go for a CT scan?
No, CT scan is okay. CT scan we can go for the CT scan, but what is more important here is that see what you are going to achieve with the CT scan. Once we know that we cannot see the vessels in the CT scan, right?
Yes, sir.
But what we can see on MRI, look at these cortical walls over here.
Hmm.
And this is abdominally bulging, right?
Yes.
So CT scan is not going to help us in any way. MRI is already showing that it's breaching the cortical wall or it's eroding the cortical wall, and the cortical wall has started bulging inside. Okay, so these are the patients which we should not touch. Okay, we can still do vertebroplasty, but before doing the vertebroplasty, we have to send this patient to the radiologist, interventional radiologist. They will embolize the feeding artery.
Okay.
Okay, so embolization of the feeding artery is important here, and then only you can go for the vertebral augmentation in such patients. Very rarely we see that, but you must know this. Okay, because looking at this hemangioma, you may say, "Oh, wow, wonderful! That's a perfect case for the vertebroplasty." But no, this is a contradiction. Why I'm showing this? Because now you have to decide this. A patient has come to you. Radiologist will not tell you this. Radiologist will mention only the hemangioma most of the times. Some very good radiologists they will mention about this. It's a malignant hemangioma, cortical regions, all these things they will mention. But most of the time they will only mention that hemangioma at L3, L2 vertebral body. That's it. Understood this point? Tissue, bone marrow. Bone marrow is again fatty. So when we look closely over the in the vertebral bodies, we can see the fatty marrow which is white on both T1 and T2. Both T1 and T2, the marrow will look white because it's a fatty marrow. Okay. Bone, cortex, ligaments, joints, all these will look dark on T1 and T2 both. Now look at the difference over here and plates over here. Okay. So this is not a fatty infiltration. This is not a fatty marrow. Because when we compare it to the T1, here it is white on both T1 and T2. So that means it's a fatty infiltration or the fatty marrow. But when I'm looking at this vertebral body, there's a darkness over here. But this is, if we compare with the T2, it is white over here. So what is this?
Edema.
Yes. So that's a hydration, right? Edema. Edema of the end plates. This is a sign of inflammatory reactions happening over the end plates. Okay. Post radiation, you may see this kind of, when it is completely replaced, or the marrow is replaced by the fatty tissues. So we may see such kind of MRIs or post radiation. Okay, so these are not hemangiomas, they are diffusely white over here. They are the post radiation fatty infiltrations. Look at this osteoporotic spine. The osteoporotic spine, you can see here. Look at this, all fatty, fatty, fatty over here, because over a period of time, there are some microfractures happening inside the vertebral bodies, and they are getting replaced with the fatty tissues. So osteoporotic spine will look like this, fatty infiltration all over here. Ankylosing spondylitis, as I mentioned, initial stages, it is always inflammatory, followed by fatty infiltration, followed by sclerosis. So depending on the stage of the ankylosing spondylitis, and not only just the stage, but as you progress upwards, as we know that ankylosing spondylitis usually starts from the SI joint, and it starts involving the lumbar spine, and then it starts going towards the dorsal spine, and it goes up to the cervical spine, right? You're aware of this, right?
Yes, sir.
Yes, sir.
Everybody knows about the ankylosing spondylitis by now. Okay, you must have seen cases also. Okay, so what happens at times, what we see is all type of changes in the spine. Okay, that means when we see the MRI whole spine, we may see in some areas there is a sclerosis, especially in the lower part. As you start going upwards, we may see some fatty infiltration over there in the lumbar or the lower dorsal region. And as you go more upwards towards the upper dorsal or the cervical spine, we may see some white type 1 changes over there, which means it is disease is progressing upwards. It started with the lower part that is already healed with the sclerosis. It has gone to the mid level, which is now in the healing phase, where we see the type 2 changes. That means white on both. As you go upwards, you may see dark on T1 on white on T2. Okay, which is a active phase. Okay, so with this we can make out, yeah, this is already healed, this is in the healing phase, and this is the area which is now active area. Okay, understood? Now look at this. Can you see here? Can you make out here? So what sequence is this?
It's a T2 sequence.
This is T1, right?
Yes.
Compare this vertebral body with this vertebral body. Can you make out the difference here? Okay, you can make out some difference, right? This is
Yes,
dark over
sir.
here, this is white over here.
Body.
So this what kind of changes it is? Inflammatory or
Infl-
fatty or sclerotic?
Inflammatory.
Inflammatory. So this is an acute phase, active phase which is happening over here.
Mm.
Now look at this here. This is white over here
White.
and this is white over here. So that means it's a fatty infiltration. That means it is already in the healing phase.
Okay.
Okay. So
Yes.
here we can see dark white, dark white. So that means the disease is progressing upwards, and now this area is active.
Mm.
Understood? So in one
Yes.
MRI, you can see all type of changes in ankylosing spondylitis.
Okay.
But if you look at the X-ray, you may not find anything. It will look normal. Okay? Understood? Until unless this goes into sclerotic phase, that time we'll see the changes as a whiteness over there. Bright white over there. That's a sign of sclerosis. Okay? So shiny border sign. You know that shiny border sign? Okay? Another feature of the ankylosing spondylitis. But again, remember, these are late features. So if you
Mm.
see the X-ray which is normal, don't just rule out ankylosing spondylitis. If you are suspecting ankylosing spondylitis, we must order MRI of the spine. Even the HLA-B27 is negative. Suspicion is there, you must rule out that. Okay. Understood? Okay, now we'll come to the sections of the MRI. So what are sections are there? We have sagittal sections, we have axial sections, and coronal sections. When we say sagittal sections, means sagittal suture, right? We have a sagittal suture here. Okay, so we are dividing the body into cutting the body into halves like this. Okay, so these are the sagittal sections. Axial sections, these are transverse sections. We are cutting the spine in this direction, horizontal direction. Okay, coronal means we have a coronal suture over here, so that's why it's called coronal sections. So that means from anterior to posterior, we are cutting the spine. We are taking the section from anterior to posterior or from posterior to anterior. Understood? Sagittal section, axial section, transverse. Sagittal is from midline towards the other side, both the sides. Coronal, anterior to posterior or posterior to anterior. Clear? Any doubt in this?
No, sir.
Okay. Now, if you look at this MRI, this section, if you can see this blue line over here, can you see the blue line here? Can you make
Yes.
out the blue line?
Yes, sir.
Okay. So this is section is taken from this part of the spine, and what we are getting from this section is this part. So what section is this? What section is this?
Paravertebral muscles.
No, section. I'm talking about
Coronal
section.
Coronal
Section.
Yes, perfect. Very good. So it's a coronal section. So that's why we can see all the muscles on both the sides because we are cutting it from posterior to anterior. Okay. Since it is in the posterior part, you can see there the sections are taken from the posterior part. So that's why we see all these muscles over there. Okay. As we start going anteriorly, we start seeing these all muscles separated by their fascia. Okay. This is going, we are going anterior, more going towards the anterior. We are still can see all the muscles over here. Now look at this. Here what has happened is that we still see we are in the posterior part. We can see the lamina, we can see the facets over here. Okay. But in this part, we are into the spinal canal. Right? Because of this lordosis. Because there's a lordosis, this part of the spine, lumbar spine, is still in the posterior part, whereas the upper lumbar and the thoracic region, we have already reached the spinal canal. That's why we can see the spinal cord and the nerve roots over there. Okay, so this is the coronal section. We start going from posterior to anterior, and we start seeing all the nerves, and we can follow their nerve roots, how they go and reach their respective foramen, and how they exit out of their foramen. Okay, understood? Okay, so what is the significance of coronal sections? So coronal sections are required when we want to follow something, right? From anterior to posterior or from posterior to anterior. When we want to follow something, we go for the coronal sections. So what are the structures which are from posterior to anterior for our significance? The most important is a SI joint, sacroiliac joint. We know sacroiliac joint is vertically oblique like this. If we want to see the SI joint completely, we have to take sections in a coronal view, right? Then only we'll be able to see the entire SI joint from posterior to anterior. You may have pathology in the posterior joint, you may have pathology in the anterior joint also. Okay, so whenever you are suspecting sacroiliitis, don't order MRI left spine. Say MRI SI joints. Then only they will take the coronal sections. If you order MRI left spine, they'll just take the axial sections, sagittal sections. Maybe you'll be having some 1 or 2 sections of the SI joint, but that will not be reflective of the actual pathologies. You'll miss your pathology. Okay, so you have to order MRI the SI joint. They will take sections from posterior to anterior. Now look at this. This is the posterior joint over here. As we go more anterior, we are going towards now this is the entire posterior joint over here. You can see this entire posterior joint. This is the capsular part. This is the fibrous part over here with a lot of ligaments over there. As you start going anteriorly, now we can start seeing the anterior joint. Now this is the anterior joint over here. Understood? Here? Okay, this is how we see the posterior to anterior joint, entire joint. you may be having some pathologies or inflammation in the anterior joint also. Okay, so that's why we must see that. Second, if you want to follow the nerve roots, suppose there is a cyst over there. In that case, we are not sure whether this cyst is coming from the facet joint or it is coming from the arachnoid space. In that case, we just have to follow the cyst in the colon section. Then we'll be able to differentiate whether it is an arachnoid cyst or it is a facetal cyst. Okay, or if there's some collection over there, suppose there's a collection over here, let's say source collection is there, we are not sure from where it is coming, then we have to follow that collection and we can make out that disc is coming from which part of the bone. Okay, all right. So this is how we have to see the coronal sections. Now we'll come to the axial sections. Axial sections means taken from like this, horizontally like this, transverse like this. Okay. Now this section is taken from this part. Why I'm saying this is taken from this part? Because I can see the vertebral body, I can see the pedicle on both the sides. Okay, I can see the canal inside. Okay, and there's a spinous process over here. This is a lamina over here. That's the facet joint over here. Okay, and you can see inside the axial sections. Can you make out here? What is this? This is the thecal sac with the nerve roots inside. And if you look at this, just medial to the pedicle, there's a dot structure here, which is your exiting roots.
Exiting now.
Okay, so exiting roots, as they go close to the foramen, they start going out of the dural sac. Okay, that's why we can see these nerve roots outside the dural sac, because now we are going towards the foramen side. This section is taken from here. Understood? Clear? And what is this darker structure?
Flavum. Ligament
Okay,
flavum.
perfect. And anterior to that is the dura with the nerve roots inside. You can see all the muscles here, paraspinal muscles, you can see the psoas muscle, you can see the quadratus lumbar muscle. Okay. As you start going down, you can see that your exiting route is now going towards the foramen, respective foramen. Now it has reached the foramen. So that means this section is taken from this part under the pedicle. Where we have the foramen, just under the pedicle, we have a exiting route over here. So this section is taken from here. We have vertebral body, we have a nerve root. We have vertebral body, we have a nerve root. Okay. As we start going more down, you can see this exiting route is going out of the foramen. Okay. And now look at this. Now we have reached the end plates. So when we reach the end plates, you see the change in the color of this. Can you see? Can you make out that? Okay. So that's the color of the end plate. This is the color of the vertebral body. It's a diffuse, slight grayish color. When we reach the end plates, it will look like this. Okay. As you start going, now what has happened to the root? Now look at this. Another root has come out. Now this is your traversing root. Okay. This is the exiting root and that's the traversing root. Rest all roots are within the thecal sac. Understood? Okay. As you go down, more down, now we are taken section from the disc. Then we can see all the annulus fibrosus. We can see the nucleus pulposus. Right? At this level, if you want to see the facet arthropathy, this is the section we must see. Axial section taken from the disc level. Taken at the disc level. Okay, so that is the section which is usually give the best view of the facet joints. Okay, now look at this. You can see clearly the facet joints over here. That's the lamina over here, and you can see the flavum. Can you make out a flavum here?
Yes, sir.
And this is the epidural space here. And this is a thecal sac. Exiting root, traversing root is now behind this. Okay, all right. So why it is important to see this? It is important to see because suppose there is a herniation, okay, whether it is central herniation, paracentral herniation, foramen herniation, extraforamen herniation. Okay, that we can see on the axial sections. And also what we can see is their relation with the nerve roots. Which nerve root is getting compressed? Suppose there is a migration, upwards migration. Suppose there is a migration over here, upward migrated. Okay, so in this case, in this section, we will be able to see the fragment over here. Okay, understood? Similarly, if it is down migration, we will be able to see the herniation over here at this level also. Okay, understood? The sagittal sections. What are sagittal sections? The sagittal sections, they are taken from the extra
to left.
from. Huh? Yeah.
Right to left or left to right.
Yes. So this is taken from the right to left. Okay. Usually it is right to left. Huh? Right to left. On the screen, what you see now, we have multiple sections, right? In that, when you have several sections, always it's from the right to left. So right is extraforaminal. As we go towards the foramen, as we take the section from the foramen, now you can see the foramen clearly. Okay, you can see what root is this?
Exiting.
Very good, exiting root. Okay, suppose there's a foramen herniation. What will happen? In that case, you will see the herniation over here. Okay, you'll see the herniation over here, and it may be compressing the root, exiting root over here. Okay, so this section will also help you in deciding when you do transforaminal neuroplasties. In transforaminal neuroplasty, what you do is you go between the pedicle and the nerve root, right? Now suppose there's a herniation over there, paracentral herniation, which is extending into the foramen and is pushing the root upwards. Okay, in that case, what will happen? If you try to enter over here, what will happen? You will hit the nerve root. Okay, so you have to see that also. All these sections you must see, even for the transfer neuroplasties. As you start going more medially, now you can see another route over there. Now, what route is this?
Traversing.
Wonderful. So when we say traversing route means it is traversing the disc. When you say exiting means it is exiting before it reaches the disc. That's why it's called exiting route, and this is called a traversing route. Suppose there is a paracentral herniation. In that case, what will happen? You will see that route is like this. Just behind this herniation. There's a compression over the traversing route. Okay. Now this section is not taken from the midline. This section is taken from the midline. If you have a central herniation, you will be able to see the herniation over here. But it is a paracentral herniation, foraminal herniation, extraforaminal herniation, and if you look at this section, which is most of the time it is provided in the big screen or the entire screen, this section is provided. Looking at this section, you may say there is no herniation at all. Okay, so don't look at this. Okay, you have to see all the sections. Okay, similarly, we go on the left side and we start seeing the traversing route, paracentral, foraminal. We can see the exiting route, and we can see the herniation, relation of the herniation with this. Okay, understood? The sequences, sections are clear. What is the significance of those? Why we need to see them?
Yes, sir.
Okay. Transition vertebrae, I think we already discussed in the philosophy anatomy. Okay, I'll skip it here. So this is the kind of images what we normally get. These kind of images we get, right? So quickly, just let's go through this. What sequence and what section is this?
T2 sequence, sagittal.
Okay, anybody else want to contribute here something? Yes, sagittal, it is sagittal. But look at the CSF here.
The first three are T2, sir.
Yes.
The
So this side is just T2 and this side it is T1.
T1.
Okay. They are provided together, not many times, just to compare. So that we can compare within one film, we can compare them. Okay. Now if you look at, I'll just make this bigger. This bigger. Okay. So this is the right side.
Hmm.
Okay. As we go, now we go towards the foramen. Clear? Foramen are clear. Okay. Clear? Foramen are clear. Nothing is there. Okay. Now we go towards the midline, towards the parasternal area. We can see some herniation over here. Can you make out?
Yes, sir.
Yes, sir.
Can you see that nerve root is compressed over here?
Hmm.
Hmm? There is a minor herniation over here, but it's not compressing the root over here. But this one is herniation which is compressing the traversing root. Okay. As we go more medial towards, we can see the herniation is becoming bigger now. Okay. We go to the center and we can see the herniation is even bigger and it is migrated downwards.
Hmm.
Okay. We go towards the left side. Again, there is some herniation over here. Foramens are clear.
Yeah.
Okay. Understood? Now,
Yes, sir.
you compare it with the axial images taken from this. Okay. Now we'll see the axial images. Look at this. This section, there is nothing. We go towards the disc level. We can start seeing the herniation over here.
Herniation.
Okay. Central herniation. Central going to the paracentral area. Okay. And extending up to the foramen.
Hmm.
Hmm? But foramen is clear.
Clear.
That's why we saw when we took a section from here, we saw the foramen was clear. That means exiting root was clear. So which root is compressed here? The traversing roots. Okay, understood? Hmm?
Yes, sir.
So this is, look at the disc level.
Disc level.
This is at the disc level. Okay, so at the disc level, it looks like it's a diffuse disc bulge,
Hmm.
right? It's looking like a diffuse disc bulge with the intact annulus. Hmm? But we saw that as we go down at the vertebral body level, we have a fragment over there. So this is the vertebral body level. This is the
Hmm.
fragment over here. Okay, understood? So this is your L1, L2, L2, L3, L3, L4, and this is a L4, L5. Okay, and this is your L5S1.
Hmm.
Now look at this L5S1. All other discs in the axial sections, they are maintain the concavity.
Hmm.
Can you make out concavity here?
Yes, sir.
So the annulus maintains this concavity. Okay, but in this case, the concavity is lost and it has become convex. And that's why if you look at this dual sac here, free TSF with the nerve roots, individual roots, but here, although it is looking like a minor herniation, but look at this thecal sac. It's so much compressed here, right?
Yes.
Because it has not only loosened its concavity, so it's not a minor herniation. It is actually a big herniation. Okay, understood? But L5S1 is peculiar is that normally it is a convex sac. Yes.
Okay.
L5S1 doesn't have this concavity. until unless if there is some lumbration or saturation over there. In that case, you may have this concavity. Okay, understood?
Yes, sir.
Okay. Now, what is this?
CT scan.
No, why CT scan? CT scan, how? CT scan may the bones will be.
Myelograms. See MRI.
No. Tell me first. CT scan में bones कैसा होगा?
White.
Yeah, it is dark, no? CT scan, the bones will be bright white. Okay, so this is MRI, no doubt. But what section and what sequence? This side is the coronal section. This side is the sagittal section.
Sagittal and coronal, yes.
Okay. What else is there? T1 or T2? First tell me. T1 or T2?
T2, sir.
Very good. You can see the CSF. So it is T2, right? What else is there?
Stir section.
Very good. So it's a fat suppressed image. That's why you can see all the fat has become darker. Bones have become darker. Whatever fatty marrow was there, it has become darker now. Okay? Understood?
Yes, sir.
On MRI, we can see the Honian, type of the Honians, the central, paracentral, foraminal, extraforaminal Honians. Okay? What is the significance of these Honians? We have to see which root is involved. Okay, whether it is exiting root or the traversing root. If it is central herniation, your traversing root is spared, your exiting root is spared. What is compressed is the thecal sac. If it is paracentral herniation, the exiting root is spared, the traversing root gets compressed. It is a foraminal herniation, the exiting root will get compressed, it will spare the traversing root, it will spare the thecal sac. Okay, but we must remember that it is not always like this. Okay, you may have the combination of central and paracentral herniation also. Okay, you may have combination of paracentral and foraminal herniation also. Okay, in that case, you may be having compression of the exiting root and traversing root both. Okay, on MRI, we can see whether it is a contained herniation or extruded herniation. This is very important for us because if you plan for the endoscopic decompression, whether I want to go from inside, we want to target the fragment from inside, or I want to target the fragment outside. Okay, for that we must rule out whether it is contained herniation or it's a extruded herniation. If it is extruded, whether it is migrated downwards or upwards, that we can see on MRI. Now look at this axial section. There's a foraminal herniation you can see here, right? Same section taken from here. We can see there's a herniation, big herniation in the foramen. Look at the foramen here. Look at the foramen here. Roots are free. But here the compression is there, which is into the foramen and is compressing the exiting root. But the target is exiting root here. Okay. Look at this axial section. You can see there's a big herniation over here. That's the root here, which is free on the right side. But on the left side, this herniation is pushing the root posteriorly over here. Okay, this is your S1 root. But when you see the sagittal sections, what we can make out is that it is not just the lateral recess, but it is also extending up to the foramen. Now look at this foramen. Okay, so this is also compressing the exiting root, and traversing root is also getting compressed. Okay, so that's why we must see both the sections. Don't just look at one section. Sequestrated disc, if you take a section from here at this level, it will look like a diffuse disc bulge, contained disc herniation. But when you take a section from the lower part, we can see there's a big fragment lying at the vertebral body level, S1 vertebral body level. This is the herniation which has gone to the posterior epidural space. It has migrated to the posteriorly. Okay. I'll skip all this. Already covered. Okay.
Sir,
Now look at, yes.
sir, what is the difference between contained herniation, protruded, extruded, and sequestrated herniation?
The difference is that when you say contained herniation means the outer annulus is intact.
Okay.
Okay. So what is the significance of that? When, let's say, if we want to decompress the disc, right?
Hmm.
There is a herniation and it is compressing the root, and we have to decompress the disc, right? So if it is a contained herniation, in that case, what we can do is we can go inside the disc and we can remove the disc material from inside, so that we are doing the core decompression and
Hmm.
preserving the annulus. Okay,
Okay.
because here the annulus is intact, so we want
Yeah.
to preserve the annulus. What we want to do, we want to decompress the disc so we can go easily inside and we decompress it from inside.
Okay.
Understood?
Okay.
If it is hydrated, we can use ozone nucleases, right? We can treat the disc.
Vasculoplasty.
Okay, we can do nucleotomy. We can go inside. We can do RF coagulation. That will also shrink the disc. Okay, so we are
Okay.
creating a space inside so that annulus will retract and it will create some space for the nerve roots. If it has come out, now if it has come out, it is extruded disc. Okay, now we have to see if it is extruded. Obviously, there is no point of going inside the disc. It has
Hmm.
come out, so we have to target a fragment. Okay, in that
Yeah.
also we have two types: one with a broad base and one with a small base. If it is broad base, in that case we can still go inside the disc with endoscopically and we can remove the fragment from inside. But suppose the your let me just make a diagram. Understand? Suppose if you have a disc like this, okay, and there's a big fragment over here. Okay, so
Hmm.
base is
Broad.
broad, okay, and another is like this. Okay, so in this case, what will happen? In this case, we can, if you want to remove this material from here, we can still go inside, okay, and we can remove this fragment from here. But if you have a fragment like this, okay, even if you go here inside, it is very difficult to remove this, right? So if it is extruded, both the cases are extruded, but in this case, we can go from inside and we can remove it from inside. But in this case, we had to go in this direction and we had to remove the fragment from there. Understood now?
Yes, sir.
So that's the significance of, and sequestrated means it has come out,
Of the disc level.
it has come out and it is detached from here.
Okay.
It is
Detached.
detached. Okay, that means the disc is here. Okay, in this case, you may see that annulus is intact at the disc level. Okay, and a fragment is here.
Okay.
Now, why this happens? What happens if the fragment is still within here? It will not allow the annulus to retract. But if it has come out, it is lying outside. In that case, at times what happens? The annulus will retract and it will seal that tear.
Okay.
Okay, so when you take a section, I just showed you the example, right? If we take a section, okay, guys, I think, are you okay with if we continue?
Yes, sir.
Okay.
Yes, sir.
Look at this. If you take a section from here, let's see. Okay, so is it not looking like a contained herniation?
Yes, sir.
Hmm?
Hmm.
Why this has happened? Because the annulus has retracted
Retracted. Yeah.
and it has sealed and the fragment has come out now. And the first
Sequestrated.
this is sequestrated. That means it is detached from the parent disc.
Hmm.
Okay, so it is free flowing inside the canal. Okay. Okay. Now look at this MRI. What sequence? What section?
T2.
Very good.
Sagittal T2.
Very good. So right side, left side.
This is first one is left side, sir, because we can see iota.
Iota.
Sagittal section, sir.
Oh, sagittal. Both are sagittal.
No, first image.
Left side is T1 or T2? Huh?
Both are T2.
Both are T2, sir.
T2 sagittal section.
Yes, perfect. Very good. Both are T2, both are sagittal, and both are T2. Yeah? Because CSF is white. Okay. Look at the disc.
Dehydrated disc in the second picture.
Yes. Here it is a hydrated disc. This is a dehydrated disc. Okay. Now, if you see some dark discs, these are not always painful. Degeneration is there, definitely, no doubt. It has lost its water content, it is degenerated, right? But this patient may not be having any pain at all. Why? Because it's a simple physiological dehydration of the disc. Why we are saying it's not a pathological degeneration? It's a physiological degeneration because if you look at the end plates, if you look at the height, it is maintained. Annulus is intact, end plates are intact, disc height is maintained. Only thing is it has lost its water. So the only problem with these patients is they will have stiffness, means flexibility is less as compared to these patients. But they may not be having any pain at all. Okay, so if you see the dark disc, don't just start treating that. Look at the end plates, look at the height, look at the annulus. If everything is intact, usually they are not painful. Understood?
Hmm.
So this is a normal physiological degeneration. Okay.
Sir, I have one doubt, sir.
Hmm.
Sir, in sagittal section, like how to differentiate whether it is right side or left side, sir, without seeing the axial sections.
The sagittal section means if it is this image, right? If you
Yes,
want
sir.
to, so this image you can say that it is taken from the center. Okay. Now if you have a one single image that's taken from the parasagittal area, parasagittal, one single image, you cannot say that it is right side or left side. You have to follow the sequence.
Okay.
Okay, understood? On axial section, yes, you can say that on the left, this side is the right and
Left
this side
side.
is left.
Left.
Okay, but sagittal section, looking at one single section, we cannot make out. Okay, now look at this hydrated disc, preserved annulus, preserved end plates, hydration is less, there's a tear.
Yes.
This tear is leading to the high intensity zone, which is the accumulation of the exudate, which is a sign of inflammation. Okay, tear leading to the loss of hydration, leading to inflammation, leading to accumulation of the exudates, and forming the HIZ, high intensity zone, which is correlates with your discogenic back pain. Okay, look at this big annular tear.
Hmm.
It's lost its water, and there's a big annular tear over here. This entire annulus is having tear. Okay, standing MRI, as I mentioned, it's not always required. Contrast MRI. Contrast MRI, when will you order contrast MRI? Whenever you are suspecting any patient who comes with the history of malignancy, comes with the back pain, especially the dorsal spine pain. Remember, any patient comes to you with the dorsal spine pain, especially the night pains, especially the night pain, dorsal spine pain, acute onset pain, you must suspect three things: either the fracture or metastasis, okay, or third is infection, okay. Even
So what significance does night pain hold here?
yes, what happens whenever these patients who are having the pathology within the vertebral bodies, okay, there is an inflammatory process inside the vertebral body. What happens when they are resting? There is an engorgement of the vessels inside the vertebral body. Okay, when we are moving, the engorgement will not take place. It will keep on moving. Okay, but when they lie down straight or they're resting stage, there is an engorgement of the vessels within this inflammatory. Whether it is a metastasis, you'll have some inflammatory component there, right? Infection, you'll have some inflammatory component there. Fracture, you'll have inflammatory component there. So what happens in the night? All these vessels will start, engorgement of the vessels will start within the vertebral body, and that will stretch the periosteum, and that
Okay,
causes.
sir. Thank you.
Understood? So remember, any pain patient coming with the night pains, especially in the dorsal spine, okay, resting pain, okay, anywhere in the body, but especially I'm mentioning about the dorsal spine because these are three important pathologies which we may miss. Okay, so infection, metastasis, fracture, all patient, even if the history is 2 days, 5 days, 10 days, 15 days, whatever it is, immediately send the patient for MRI, preferably contrast MRI. If you have high suspicion, send for contrast MRI. Okay, and also whenever we have a patient who is referred to you post intervention or post surgery, this is going to happen. Post intervention or post surgery, if the patient is referred to you, he give some epidural, give facet, give this, give that. Don't do anything without getting a fresh MRI. Inquire from the patient what was the condition before the surgery or before the procedure. Okay, ask about the history, what happened after surgery, whether they improved or not, or your symptoms have increased after the surgery, after the procedure or not. If the symptoms have increased after the procedure or surgery, any discal procedure, immediately after the procedure, you must suspect infection. Okay, and for that, in the initial phase, it is only the contrast MRI which is going to show you the difference in the inflammatory component over there. Okay, so any patient referred to you post intervention, post surgery, don't do anything based on the MRI which may be there with the patient's pre-operative MRI. Okay, based on that, never ever do any intervention. Ask for a fresh MRI, preferably contrast MRI. Okay, understood? Clear?
So
What
till
are
what duration the MRI is valid, sir? If a patient comes with previous MRI of 3 months duration or 4 months or
nothing?
2 months.
Not at all. Even if it is 10 days old, patient has undergone surgery 2 days back, it is not valid. Simple.
No, sir, in general, so not about surgery. If any patient comes with
Oh, that
back
way.
pain.
Okay, so you're talking about the patient has come to you and patient says
Yeah,
I'm doing MRI
yeah, 3 months
6
back or
months
four
old, 3
months back.
months old,
Yeah,
6
yes,
months old, you know,
yes,
till what time it is valid. That is what we are
yes,
okay.
yes.
It depends on the symptoms of the patient. If the patient
Okay.
comes to you and says this, I'm having this back pain since last 6 years, 5 years, I'm suffering, okay, and then suddenly my pain increased, and then I went to a doctor and he got my MRI done. This is my MRI for 6 months old. Okay, now you have to ask the patient what happened in last 6 months.
Mm.
Patient may say that time my condition was very severe. Now after the medications, after the physiotherapy, rest, all these things, my symptoms have improved, but it is still there. Which means nothing new has happened, right?
Mm.
In that case, even if it is 6 months old, this may be valid.
Okay.
Okay. But a patient comes to you, patient says, this is my 3 months old MRI. That time my condition was, I was able to walk, but I was getting some radicular pain. Okay. Then I took some medications. I was a little bit okay for some time. But now since last one month, my pain has increased. I'm getting numbness also. I'm getting paresthesia also. What has happened now? The symptoms have
Mm.
changed, right?
Yes, sir.
Now this 3 months old MRI is also not valid.
Mm.
Clear?
Yes, sir.
Very, very clear in ordering the MRI. Don't
Yes.
feel shy in ordering MRI. Don't feel shy. Nobody is going to protect you if you do something without your diagnosis or something else is there inside. And if you do something, right, nobody is going to protect you. Everybody is going to ask you why you didn't get to go for the MRI first.
Mm.
That time nobody will say you are saving the patient, patient was poor, patient was this, patient was that. Nobody is going to listen to all these things. Okay.
Yes, sir. Thanks.
In India, we have infection also, tuberculosis, hot spine, securities, tuberculosis securities. All these are not uncommon. Understood? So we had to rule out that also. Okay? Yeah.
Yes, sir. Thank you, sir.
Contrast MRI is also again good for this. Suppose the patient comes to you with the multiple compression fractures over there. You know? So they may be, some of them may be old fractures, some may be acute fractures, some may be subacute fracture, and you have to decide which one is causing pain. In that case, you can go for the contrast MRI, see which one is getting enhanced. That is the active fracture. Okay. Now body changes, type 1, type 2, type 3. Type 1 is basically edema, type 2 is fatigue replacement, type 3 sclerotic changes. Now, now what is the source of pain? Here, the source of pain is inflammation. Simple. Body type 1 changes, inflammatory changes happening at the end plates because of the microfractures which are happening at the end plates, leading to the inflammation of the end plates. Okay, so what we'll do in these cases, our target is the inflammation. Okay, so in this case, we have to go for the anti-inflammatory components. Maybe intradiscal steroid, intradiscal steroids, or ozone, or methylene blue. What are all those options are there? Maybe systemic steroids, whatever. Okay, because we have to target the inflammation. Simple. If you have a type 2 changes, fatty replacement, in those patients, these are the patients who may having vertebrogenic pain or the discogenic pain. In this, the nerve have grown inside. Inflammation has set in. Okay, but the nerves which have gone along with the inflammatory process, those are still there, and that is causing pain. In that case, we may have to go for the vertebral augmentation, or we may go for the disc denervation. Okay, mycoplasty or disc denervation. Okay, so that means we have to denervate either the vertebral body or the disc. Okay, the third is sclerotic. Now, if you look at this, this is looking like horrible, right? It's most horrible among these three, right?
Mm.
But these kind of desiccated sclerotic end plates are not painful because now disc is totally desiccated. It's a dry disc. The end plates are sclerosed, which means there are no nerve endings over here now. Okay, understood?
Yes, sir.
In the sclerotic bones, there is no nerve endings. In the dry desiccated disc, there is no nerve ending. So these discs, end plates, vertebral bodies, these are not the source of the pain. But what happens because of this changes, what is happening in this area, it will cause secondary changes to the facet joint, to the muscles surrounding areas. So those become painful. So you have to target those other structures. Clear? Understood? What is the importance of understanding this? Okay. If you have annular tear like this, you can definitely go for the annuloplasty. Hmm? Annuloplasties, which are very good procedures. We discussed this. Now this is you can see this is T1 image. It's dark over here. T2 image is dark white over here. Contrast enhancement. The contrast enhancement, you can see some collection over here. You can see some collection over here. You can see some end plate changes, sclerosis, erosions over here. So this is not just a simple fracture. There may be some pathology. Most probably it's an infective pathology which is happening.
That's fine.
Yes. Lumbar canal stenosis, we can see on MRI grade 1, grade 2, grade 3, grade 4, depending on the type of the compressions. Now, if you look at this, in all the cases, disc is not the source. Okay, what is the main source here? The main source is the flavum. Main source is the facets. These are compressing the entire thecal sac over here. Okay, grade 1 is, that means CSF is there, all the nerve roots are free. There's some crowding is happening over here. There's a compression of the thecal sac. Grade 4 is completely compressed. We cannot make out differentiate between the nerve roots. That is grade 4. This you can read about CLS score. This basically gives you the idea about where we can go for the decompression and fixation surgeries. This is MRI of a patient, actual patient, who is having all the pathologies, whatever you name that pathology, and it is there. Okay, all the pathologies are there, and patient was totally pain-free here. There was no pain at all in the lumbar spine. Okay, can you make out disc desiccation, vertebral fractures, right? Facial hypertrophy, ligament of limb infolding, all the pathologies are there. But patients said, I don't have any back pain at all. Okay, so we'll not do anything here. So this patient was having actually compression fracture at the D6 level. Ligament of unfolding, you can see on MRI. Now look at this. In this case, what is happening here? It's not the disc which is compressing the nerve root. It's the flavum which is causing compression. Right? It's the flavum which is causing compression. Okay, so in this case, we have to decompress the flavum, not the disc. There's no point of going inside the disc or removing the disc from here. It's the flavum we have to target. That we can see on the MRI. Facet joints, as the disc start degenerating, it puts a pressure on the facet joints. Facet joints goes into degeneration. You can see some hypertrophic facet joints over here. This normal facet joint. This is a completely degenerated facet joints. It's an inflammatory component here. There's a fluid inside the facet joint. Now both are facet arthropathy, both are painful, both may have a different presentation. Treatment is also different. Same level, same patient, same level, treatment is different. Because it is inflammatory component, there is no point of denervating the joint. We can just simply go inside the joint, aspirate it, put the steroid inside, it will take care of that. There is no point of intraarticular here. It's totally degenerated joint. We had to denervate. We had to do the medial branch ablation over here. Okay, same patient, same level. One side we'll do intraarticular, one side we'll do denervation. Okay, all right. So this you can just quickly go through this. You can see here there's a disc herniation, no doubt. All roots are free. Traversing roots are free. Okay, this side traversing root is free. Central herniation, but there's a compression over here. What is compressing this? It's not a disc. It's a flavum which has gone inside. Compare with this. Why this flavum has gone inside? Because there's a inflammatory component which is in the facet joint. Lot of correction there. It's pushing the flavum inside and compressing the root. In this case, we can avoid a major surgery. We can just go inside. These are all actual patients, where we actually did this thing only. We just remove this. You can see cyst over there. We just remove the flavum. No, sorry, this one, the aspiration. That's it. And patient had absolute relief. Facets, both the sides. Past defect, we can see on the, so there's no fracture over here, but there's a edema over there, which is a sign of some trauma over there. Ligament buckling, as I just mentioned, ligament buckling that may cause compression of the nerve roots, that may cause stenosis. So in those cases, we have to target the flavum. Not many times we just go from posterior side, we just remove the flavum endoscopically. That's it. We don't even go to the touch the disc. Synovial cyst coming from the facet joint, it forms a cyst inside. It may cause compression of the roots over there. We can either aspirate them from the through the facet joint. Okay, we can aspirate them. Don't inject anything because it will again inflate the cyst over here. So don't inject anything. Just do multiple punctures over there. Come out. That's it. Maybe just a 0.2 ml of dipomedol you can inject, but don't inject any contrast or the high volume of the drug inside. This is a cyst. Again, you can see there's a cyst over here, but this is an organized cyst. Obviously, we cannot do anything for this. We have to decompress. We'll have to remove this either endoscopically or surgically. What is this? What is this? Anyone?
Facet diffusion.
Anyone else?
Lipoma.
Lipomas.
Very good. So it's not a fusion. Why it is not a fusion? Because it's a T1 image, right? It's a T1 image. If it is a fluid, what will happen to the fluid on T1?
Dark.
Fluid.
Dark.
It's a lipoma. Okay, it's a epidural lipoma. Understood? This is the organized cyst over here. Organized cyst, probably coming from the facet joint. This is a arachnoid cyst. You can see there's a nerve root inside and there's a covering over here with the CSF. Don't touch this. Don't touch this. Okay. Look at the coronal sections. See from where it is coming. If you're not able to make out the nerve root inside, you just have to follow the coronal sections. Okay, like this. If you see here, there's a cyst over here. If you follow with the coronal sections, you can see that it is coming from the nerve root. Okay, so to see this cyst, we have to see the coronal sections. Discal cyst, high intensity zone, inflammation process going on, it may form the discal cyst. Okay, in this case, we have to decompress the cyst here. Discitis, this may happen as a complication also, with your intervention also. There's a possibility any patient after your intervention, interdiscal procedure, comes to you maybe after 4 weeks, 2 weeks, 5 weeks, 6 weeks. Okay, and for that period, he was absolutely fine. For initial 2 weeks, patient may say, I was absolutely fine after the procedure, but since last 1 week, I'm having severe pain, stiffness. Always suspect discitis. Discitis may take some time to develop symptoms. Till the time the infection is within the interdiscal, within the nucleus pulposus, it will not cause any pain. The moment the infection spreads towards the end plates or the annulus, outer annulus, then only patient will have pain. When it reaches the end plates, it will cause severe inflammation. And that's why the patient will come with a severe back pain and stiffness. So any patient after interdiscal procedure comes to you after 4 weeks, 2 weeks, 4 weeks, 6 weeks, immediately send the patient for contrast MRI. Don't wait. Pot spine, tuberculosis, we must rule out this. Okay. You can manage if it is not compressing the roots. You can still manage with the patient with the ATT. You can manage these kind of patients. Don't do any intervention in such patients. If it is compressing the roots, refer to the surgical colleague. Spine metastasis, okay, this will cover in the vertebroplasty. Okay. All right, guys. So that is all.
So can we differentiate an inflammatory pathology from an infective one on MRI?
So inflammatory pathology and infective pathology, what we see is the erosions. Okay. In fact, inflammation will be there with the infection. But if it is purely inflammatory, in that case, the erosions will not be there. maybe the very late feature.
Okay, sir.
So if the erosions are there, then you should suspect some infective pathology.
Okay, thank you, sir.
Yes, guys. Anything else?
Any other doubts? I'll just check the chat box. Multifidus muscle dysfunction in case of bilateral facet joint intervention.
See, what happens is that multifidus uh, atrophy and other things, whatever now people are making a lot of hue and cry of this. Uh, Practically, we are not seeing such that with the median branch ablation, patients are going into multifidus dysfunction or the atrophies. Okay, why this happens? Because all these multifidus muscles, they have multiple supplies. It is not only that one nerve which is supplying the one single set of the multifidus muscles. They are having multiple supplies. So if you are even ablating the one nerve, median branch, it will have some supply from the lower one or upper one also. So that may be the reason why we don't see very commonly the multifidus dysfunction or the multifidus atrophy.
Yes.
Okay, that is one. But remember one thing, at times what happens, there are some anatomical variations which are there, okay, where when you stimulate the medial branch, you will see a series of the multifidus muscles are getting stimulated. Okay, this is an abnormality which is there, which is a not abnormality, I can say it's a anatomical variation is there. So there are some anatomically variants are there of the medial branch, which the single medial branch which goes and supplies multiple multifidus muscles. So if you are getting a stimulation, and if you see that multiple levels are getting stimulated, we see the contractions, paraspinal contractions happening at a multiple level. In that case, you should never do. Don't ablate. Don't ablate that nerve. In that case, definitely patient may come with a tilted spine. Okay, so you need to be careful about this anatomical variation. Very rare, but you may get.
Yes.
So one more query.
Yes.
It is said MRI is helpful in case of acute vertebral collapse or fracture, where the vertebroplasty or cementoplasty helps. But role of 3D CT or MRI in chronic vertebral collapse fracture, so
See,
whether to intervene chronic fractures or not.
see, 3D CT is not going to help you in deciding the chronic fractures. If you talk about the acute and chronic, whether it is going to help you or not. You know? Definitely, if on MRI, even if it is a chronic in the terms of duration, if you talk about duration, let's say a patient comes to you after 6 months of the injury, right? And if you get an MRI done and patient says, initially I was having severe pain, okay, then I took this breast and other things, I took rest and everything, then my pain settled down, but now again since last 2 months I am having again the pain. Okay, you have the previous MRI, you take a fresh MRI. Okay, you take a fresh MRI, and if you see that edema is still there, okay, now what must have happened in last 6 months, it has already healed. Okay, but there are chances of refracture within the same vertebra. This happens in the osteoporotic spine. Okay, in that case what will happen, there will be a refracture and again there is edema.
Okay, sir.
Okay. So on MRI, if we see the edema is there, that means the source is still there. That means either the fracture has not healed completely, or there's a refracture which has happened. So if the edema is there, you can proceed with the vertebra.
Vertebroplasty.
Now your question comes, if it is a chronic fracture, right? And on MRI we don't see much of the edema. I don't see that there is hardly any edema. Okay, but I can see some darkness inside Now, whether it is a sclerosis or it is something else, okay, for that you can go for the CT scan because there is some variation which is called a cleft fractures, right? What happens? There was a fracture, okay, the fracture plates and plates they have healed, but there is a non-union
Mm.
and that has left a cleft inside. Now, because there's a cleft inside, the fracture is still moving, but it is not visible, and that movement is causing pain. Getting point? On
Yes.
MRI, on MRI, if it is dark, on MRI, if it is dark, there may be some vacuum phenomena there. Okay. Now on MRI also there are two variations, two variants of this cleft. Some cleft they are air filled or they are water filled. Okay. Now
Okay.
that depends on when the sequence was taken.
Mm.
Okay. What happens in this cleft fracture when the patient lie down supine initially for few minutes, 10 to 15 minutes, they are filled with the gas. Okay. When they lie down for 10 minutes, 15 minutes, then the water start accumulating over there. Understood? So,
Yes, sir.
so on MRI, you may have a fracture is there, but there is a dark line inside or the white line inside. Get your point? So,
Okay.
if it is a dark line, in that case, only we have a role of CT scan, which will differentiate whether it is a sclerotic inside or it's a cleft inside. Understood? Maybe I'll show you the picture. Look at this. I'll show you better. Okay. See this. Can you see this? Guys? Are you there?
Yes, sir.
Hmm? Right? So this is what? This is
Fluid.
fluid filled
Wait.
cleft.
Yeah.
Okay, there's a cleft which is filled with fluid. Okay, if the sections are taken within like 5 minutes of patient lying, within an
Hmm.
MRI, this may be dark also.
Okay.
Okay, understood? Here,
Yes.
okay. Anything else?
So one more last question.
Yeah, please.
Can we proceed for sinovertebral nerve RFA or something in type 2 modic changes?
See, again, there's a lot of talks going on about the vertebrogenic pain and basivertebral nerve ablation with the radio frequency. Hmm? Personally, I'm talking about personally, you must know that, okay, what is vertebrogenic pain, what is basivertebral nerve. But personally, what I feel is that this is not a good option. The reason behind this is that there are two reasons. One is when we have to target the basivertebral nerve, where we have to go in, where we target the basivertebral nerve.
Into the vertebral body.
Yes. So we have to go inside the vertebral body, right? We
Yes,
have to
sir.
go inside the vertebral body. Okay, it's not like simple key that we are going around the disc or around the facet, right? We have to go inside the vertebral body. That is one. Second is when we do any ablation, before ablation, what is the prerequisite?
Sensory and motor stimulation has to be present.
Before that, you have to have a positive diagnostic block, right?
Yes, sir.
Are we doing that in vertebrogenic in RF ablation of the vesicle?
No.
To do that, we'll have to go inside the vertebral body to the to do a diagnostic block, right?
Yes, sir.
Okay. So firstly, we are not doing any diagnostic block. Secondly, when we go inside the vertebral body, which is already sclerotic or some fatty infiltration is there, how is it possible to move that catheter inside? At times, in such patients, it is difficult to inject a cement also. Understood? And how
Yes,
can
sir.
we go inside the vertebral body and we can stimulate the nerve,
23 hours.
identify the nerve over there? So neither
Difficult.
neither the stimulation is possible, sensory motor, nor the diagnostic block we are doing. So what we are doing is we are just going inside, we are ablating inside. What we are ablating, we don't know. Get my point? So if I have a vertebrogenic pain patient, I am doing tomorrow, I think tomorrow, day after tomorrow, I'm doing this one case. Patient is typical vertebrogenic pain. Okay. In that case, I would prefer to go inside. If I do go inside, I'll inject cement inside. Okay. The cement will give stability also. It will burn
Exothermic
the nerve.
reaction cause the yes.
It will burn that nerve also.
Yes.
Right? So if
Yes,
I
sir.
go inside a vertebral body with that thick trocar, I'll might as well inject a cement inside, I'll come out better.
Mm.
Okay, understood.
Yes, sir.
But these are my views. Okay. For your exam, if somebody asks you, you talk about a mercy button or only. Okay.
Thank you, sir.
So don't argue with the examiner, huh? Pankaj sir said this.
So, yes.
Chalo.
Thank you very much, sir.
Thank you, Kashinath. Thank you
Such a wonderful, elaborative 11th hour lecture. Thank you very much, because this is one lecture where clearing all the doubt is must,
Yeah.
because
very-
there is no escape for this, and you have done very nicely. Thank you very much, sir. Thank you.
Thank you, guys. Thank you, guys.
It's
So, guys,
always pleasure to learn from you. Every time we hear, it's new. Thank you very much, sir.
thank you.
Yes, sir. Good
So,
night.
guys,
Thank
start
you, sir.
doing the MRIs.
Thank you,
Huh?
sir.
Start doing. Whenever you have any patient, any surgical patient, whatever it is, right? Don't look at the MRI film or the reports. First, see yourself. Everything. Read it thoroughly. Hmm? Any doubts? Anytime we have this group. You can just post those MRI pictures. Okay, we can always discuss.
Thank you, sir. Good
Yes,
night.
sir.
Okay,
Thank
good
you.
night. Good night.
Thank you, sir.
Nice.
Thank you,
Thank you,
sir.
sir.